Hello, Miss Oertelt-Prigione. I'm glad you're here. Would you like to introduce yourself? Thank you for the invitation. I'm Sabine Oertelt-Prigione. I have a chair in gender medicine in the Netherlands at Radboud University in Nijmegen. And I also work here in Berlin at the Charité teaching hospital. I work with gender medicine, differences between the genders in medicine in the broadest sense. So both structurally speaking, but also content of teaching, public information. So what fascinates you working in Europe in teaching and research? You've studied all over the place, I think, and been socialized in different places. Well, I found that very enriching, having lived in different countries and worked and studied in different countries, because as a result of that diversity, it's changed my view. I think I wouldn't be doing what I do now if I hadn't studied in these different places. The way I look at my work, the way I address solutions has been influenced by these different perspectives. Because I grew up abroad, I grew up in Italy, I learned very quickly that there isn't any such thing as one solution. There's one problem, but there will be at least two, probably more solutions. And in all the other countries where I've lived, it simply broadened my spectrum of potential solutions. I think that's very enriching, especially in the current time. Our problems are becoming increasingly complex, so I think that's very helpful. Enriching, as I say, and I think it's reflected in my team as well. You say of gender medicine that it's about both the cell and the human being. Why? That's a bit to do with how we define gender medicine. In Germany, we tend to have one word for both sex and gender, as there used to be in English as well. In English now you have this differentiation between sex and gender, and that is reflected a bit when we talk about cells. We can't talk about socio-cultural gender because cells aren't exposed to that kind of thing. There are just biological differences which play a role in genetics and so forth. With human beings, as soon as gender plays a part, when our brain plays a part, everything we experience, who we are, what makes us different, is going to influence the way we deal with things, including our health. So not only our biological sex plays a role there, but also our socialized gender. We see this in depression, don't you? Depression is diagnosed twice as often with women. Why is that? Is that a gender issue? Well, there are different factors at play here. Probably, and we've seen that in recent studies, probably there are genetic differences between men and women in terms of depressivity, but at the same time, our criteria are probably better geared to women when we diagnose, because we know now that depression doesn't express itself in the same way in everyone. Women are more likely to lose their drive, to be sad. With men, perhaps they are more likely to externalize their depression, perhaps become more aggressive in their behavior, maybe drink more. But the basic problem is similar. For a long time, we simply didn't recognize that. And that has in turn to do with what we as a society expect from people when they're depressed. How do we expect men and women to behave in this situation? And we need to address that. So yes, women do have a higher incidence, but it may well be that that's to do with the criteria that we apply to recognizing it. And we may now see more diagnosis of men. What about suicide? Men have such a high suicide rate. Well, we know that men are certainly more effective when it comes to attempted suicides. They are more frequently successful, unfortunately, when they try to kill themselves. That's partly to do with the way they do it, the weapons, if you like, the instruments that they resort to. Women are more likely to use pills of some sort, and men are more likely to shoot or hang themselves. So attempts at suicide are more likely to be successful in those circumstances. With women, if they're taking pills, there's a certain time when they might be discovered, and that might thwart their attempt to commit suicide. Another issue, when you train doctors these days, they now have dummies with breasts. Why is that? For trainee doctors, it's important, but also for the general public, because we know from a study from the United States that especially in the general public, if someone collapses on the street and needs to be reanimated, the first aid people, the people who come to help, very often don't know what to do with the breasts. That might relate to training. If you're doing a driving license, for example, and you take a first aid course, this is a question: how do I deal with the breast? Usually, the dummies that are used don't have breasts. So then the question, what do I do? Am I allowed to touch it? Can I push it aside? Where can I press? I think that has something to do with embarrassment to some extent. But at the same time, this person's lying there and I need to save their life. It's a problem that needs to be resolved. And this study showed that women are reanimated in 27% fewer cases on the street than men. And that is a primary factor, how to deal with the breast. And women have breasts. It can happen to women too that they don't know how to deal with it. But it can also happen that a man's lying there, and because he's overweight, he might have breasts too. It's not only women that have breasts. What about medication and studies? Yes, in the old days, in clinical studies, after the thalidomide tragedy in the 70s, a collective decision was made to exclude women from clinical studies. Can you explain about thalidomide? Yes, it was a sleeping tablet that was often given in the 70s to women, even when they were pregnant, because the assumption was it was pretty harmless. But thalidomide is extremely harmful, and it was only later, when the women gave birth to children where to some extent the limbs were missing, that it was recognized that they had all taken this sleeping tablet, thalidomide, and that alarmed the medical community and also the pharmaceutical manufacturers. The question was, well, if they're not tested on women, if they're not tested on pregnant women, how would we know this? So the first decision that was made was to just a blanket ban on all women in clinical studies, just in case they were pregnant or about to become pregnant when they were involved in the study. But of course, it was partly because the companies, the industry, didn't want to incur the risk of this happening again. But women were no longer taking part in these clinical studies. In the 80s, 90s, women were not admitted to those studies. Until in the 90s, it was decided that maybe that wasn't such a great idea, because very often these drugs, before they are tested on or allowed for use with human beings, are tested very often only on animals, and they'd only been tested in many cases on male animals because the difference wasn't recognized. And researchers in the United States looked to see what adverse effects there might have been. And of course, these side effects were measured in the overall population, not specifically in men and women. And it turned out that they often had far more adverse effects, sometimes fatal ones, than the ones that had been tested. And in the early noughties, after the millennium, it was found out that very many of these things have far more adverse effects in women, often fatal, and therefore it was decided that women had to be included in clinical studies, especially if they were going to be prescribed for women, these medications. I think the time has come for a little introduction. What is gender medicine? What do you actually do? Gender medicine, or gender-sensitive medicine, or gender-specific medicine, there are different terms, also depends a little which side of the Atlantic you are, is basically about gender differences in the genesis of disease, in the diagnosis of disease, and in the treatment of disease. And it's not about illnesses that only one gender gets. It's not just about breast cancer and prostate cancer, for example. It's also about all the diseases that affect all the other organs and what differences there might be between men and women. And through the studies, we can perhaps find out that there might be cultural differences, or that we need to address things, use different diagnosis methods. The problem is when you only have one model, it's difficult to address different expressions of a particular disease. And very often in medicine, if you look at the symptoms or diagnosis, the same model is applied to everyone. Osteoporosis is considered to be a typical women's disease, and we have standards for women. Or depressivity, for example, very often oriented to women. Prostate cancer, men, and so forth. But we carried out studies, and now we're seeing increasingly that the criteria we have aren't adequate, and that very often the form these diseases take in other genders, we have to say now, aren't reflected in those criteria. So now, of course, things go further because we have transgender specific models as well. Unfortunately, not very much yet. There is fortunately some activism, because if we rely entirely on the general community, unfortunately things will take a bit longer. So transgender, intergender differences in sexual development communities are very active, fortunately, so that the images we have in medicine are being challenged or questioned. They certainly don't fit the modern age or the year 2019. So we have to ask ourselves, what does that mean? How do I talk to patients who don't match my standard views? What is the best way to provide them with care, to provide the right therapy for them? How can I talk to these people without them feeling in some way rebutted because of who they are? And it starts with, and this is, if you start with transgender people, if they're taking treatment, what does it mean for me as a GP? What do I need to monitor? Are there things that are particularly important here? Are there things I need to measure more frequently because the hormones are different, for example? Or is there a cardiovascular risk? Do I have to screen differently? What can I do to make sure that for all my patients, including healthy people who simply come along for a regular screening, to address these things more specifically? What's the state of affairs now in Germany, or indeed in Europe, in gender-sensitive medicine? I think it varies a lot, and it does depend a great deal on individuals. We're seeing a generation change at the moment. A lot of the women, primarily in the first generation of gender medicine, there weren't many men involved, but a lot of these people are now entering retirement or gradually ceasing to work so much. So there's a generation shift underway. And very often the research depended on a particular person or a group of people. Very often it starts like that. Gender medicine is almost always started by an individual or a small group of people. Very often it doesn't take place at structural level yet. And if an important person leaves, then very often the theme is no longer addressed. And in Europe we don't have a structural implementation of gender medicine. The Austrians, I think, have made the most progress so far. But in addition to that, there is no structural implementation. So it does very much depend on these key figures. A lot is happening in the community at the moment overall, but there's still a lot to do. Should we consider this as gender studies? So if Orbán in Hungary abolishes gender studies, will that also affect research in gender medicine? It's complicated, the relationship between gender studies and gender medicine. It has a lot to do with the way you interpret it. From my point of view, I have a very broad interpretation and I work closely together with gender studies, but there are some colleagues who have a much more biological focus and don't really relate so much to the gender issues. They're just looking at the molecular level of gender difference, and there, to some extent, the interaction with gender studies is more difficult. Perhaps I could describe it this way. It's not so simple because this whole movement, how one defines gender, is sometimes still quite linked to the idea of gender difference. And gender difference can then be instrumentalized in gender medicine to carve things in stone. And then to argue, so there is a natural family that requires one of each. And if you have insights that derive from the idea that you have to recognize difference, diversity, in order to provide better treatment, then you have to say, okay, it's not enough to say we have two poles and that's the way things have to be. We have to be much more differentiated, much more cautious in the work we do and the things we say and what we try to achieve. Let's come on to digitalization. Algorithms are based on data, and normally that data is fed by white men, and that's why they tend to relate to young white men. Why is that a problem for women? Well, because they're young white men. I think at the moment, on the one hand, we have a great deal of expectations from digitalization, machine learning, algorithms are going to save us and we're all going to lose our jobs because they'll do everything for us. But joking apart, of course, at the moment, the question is how do we respond to that? Because ultimately an algorithm is only as good as the data that's been fed into it. And hence, there's a risk here that if the data is biased from the outset, it can only represent a certain section of the population. So if you have a huge data set, especially if we want to use that very quickly and we don't know what happens very often between the input of data and the algorithm that comes out, there's a huge risk there. There are a lot of initiatives underway now about responsible AI, AI now, and all these questions. It's not just about women. It's basically about anyone who isn't a young white man, people of colour, people who perhaps don't respond to our idea of a normal body, people who, for religious reasons or whatever, wear different clothes or present themselves differently. It might have something to do with sexual orientation. If I present to an algorithm, it can't necessarily tell the difference. And the more data sets we have and the more algorithm, the more that'll affect medicine and other things too. So it's not that algorithms are bad per se. We're going to have algorithms. They're going to be used increasingly. They're going to be integrated more. But we have to have an awareness of what data is being fed in there and how, and what do we do with that data. And let's be quite clear about what's going on in this process. If we do traditional statistics, we can say quite quickly, okay, we can then work out what happens where. But with machine learning, we can't always understand where it's come from. So, I'm sure it's an issue where this potential bias has to be addressed. You were doing this seminar at the Free University a few weeks ago, and you mentioned an example. Can you tell us about the example? Yes, it's work by Joy Buolamwini at MIT, a person of colour, so not a white skin, and she was looking at commercially available algorithms for face recognition, and she saw, trying to use some of these algorithms, she put her face in front of the computer and the algorithm just didn't recognize her, or recognized her as a man, either as a man or not at all. She put a white mask on and suddenly she was recognized, and then she said, uh-oh, something's not right here, and we have to take a look and see what's going on. So she set up a big panel of people from different parliaments around the world with different skin colours and so forth. And this was a spectrum from very pale skin to dark skin, male and female. She used those in the program to see who is recognised and how are they recognised. And it confirmed, yeah, if you're a white man, works fine. As soon as you're not a white man, it's trickier. And then the algorithms are different. Some will recognise all men, even if they're not white, but not women. And some algorithms recognise white people better than dark people. So as long as you're Caucasian with a pale skin and male, you're fine. And it simply showed that these algorithms are trained on a specific set of men. Millions of images are fed into those algorithms so that they can be trained. And of course, something happened there which didn't enable the algorithm to pick up other types of face. Is it a bit like the generic masculine in language, where the masculine form is used to allegedly refer to women too, and it's not entirely logical? Very often the statistics are so diffuse now in terms of people's gender, or sex even, that, let's say, you can tell any story you like with them. Yes, the assumption that the generic masculine is theoretically, it may be wrong, is that it's supposed to apply to all of us. But with algorithms, we've seen that only one category was recognized. Of course, the generic masculine is a problem, and we know from studies that if we want to address women directly, they feel it's much more relevant to them, for example, in job applications. And in all these scientific theories, they tend to use the masculine, the generic masculine, and you often don't know. Are they talking about everybody, or are they just talking about men? Yes, there was a study that Londa Schiebinger did in Stanford that showed if you use Google Translate and you translate from English into another language, into most European languages distinguish between male and female people. They have a word for each. So when I'm translated into other languages from English, I am described as Mr. Professor. And the same with doctors. A female doctor will appear in other languages as a male doctor, in Spanish or Italian or German, because the English word doesn't tell you. So this assumption is made by the translator system. You've also done a lot of work on the prevention of sexual harassment. To what extent is that gender medicine? That's a very interesting question, because I'm quite often asked by colleagues who don't understand why the team are working on prevention of sexual harassment. Why are we doing this? Well, we're not just talking about equality work here, we are actually researching this topic. It's not just a political issue. And we believe that we can only put the message across to a broad public if we work with a system. If you have a system based on how we talk to each other, how we deal with each other, and so forth, and certain standards, that's fine. But as long as we don't have it, it's very difficult to say to colleagues, have a close look at your patient. Who are you talking to there? As long as we don't know why certain standards have to be met, it's difficult for a doctor, perhaps who's training, to understand why a patient needs to be addressed a certain way. If I have a diverse team with lots of different people, it's much easier to understand for that team how I can translate that into the way I deal with my patients, or how the public can have their awareness raised about that. You've been working with Christina Kohlmeier here at the Charité on a study on migration. And we know that women migrants tend to have quite different experience of their journey compared with men, very often much worse experience. And when we talk in general about migrants in politics, it doesn't respond to this. Yes, quite simply, women are simply taken on board, if you like. And if you work with migrants, very often the policies are geared to a standard migrant in inverted commas. And then it turned out that they have very different needs, and the intervention policies have to be very different. A lot of the policies simply don't reach out to women. For example, if I set up language courses on the other side of town and it takes 2 hours to get there and back, and I don't have childcare where the women are living, then I can't expect them to take part in the language course. So what happens to migrants when they get to Germany? It's not just about differences in their countries of origin. It's not just about the journey. And of course, women and men had different experience. But what happens when people get here? If you suddenly find yourself in a society where the gender roles are very different, what effect does that have? And how can you support people? We need to think about that in order to integrate people properly. And like I was saying before, with diagnosing illness, we can offer the support, but we need to look first, who are we dealing with? And for young people, this would be interesting too. What would you recommend if we're talking about exploitation in call centres or sex portals or sexism in general? In work situations, from the laboratory right through to personal situations, what do you recommend to doctors, to trainees? I think there are different levels there. There's the working context and there's the general context, the world we live in. And at work, we are able to set up a framework to some extent by statute or by setting up rules. We have an Equality Act in Germany, as in other countries. We have house rules, contracts, and to some extent we can rely on these. Sometimes it works well, sometimes it doesn't. We need to go further. But then there's my life outside the working sphere. That's a lot less protected in that respect. And I think we simply have to inform and start educating people very early on. Children should, in school, develop an awareness for what happens on the internet. For example, these days, children have access to the internet that we didn't have because to some extent it didn't even exist what they do now. And at a young age they are using laptops or have their own laptops, and I think we have to start really on talking to children about the roles that are offered on the internet. You can't prohibit it, but you need to work with them and say, look what's happening here. I never stopped my daughter playing with Barbies, but I did point out that a Barbie doesn't look like a normal woman. So it's not about prohibiting the children from interacting with things or playing with things, but to have this awareness and say, look, you're being exposed to this stuff and you have an opportunity to be critical of that. I think that is so relevant to the network, and we need to start early, not at some point when people are young adults. It's too late. Yes, of course, information, education is always important for everyone about the internet and on the internet, even if it requires some effort for people. People want to have an easy life, perhaps. But as we're talking about the internet, there are so many porn videos now, accessible for anyone. And just imagine, young people can get hold of them too. If people are going to have a positive, healthy sexuality, what can be done? Yes, it's not just about young women, it's also about young men. A certain image of women is presented there, but also certain expectations of men are formulated by these videos. If I look at the actors, and for half an hour you see women performing this sexual act in all sorts of positions, but you never see their face. But also men, what men do is not normal either, and that's also something that needs to be addressed. It applies to both sexes. I would never prohibit my child from looking at these things. Ideally, I would start talking to her early about this and say, look, you're being shown this stuff. It's not the way I behave. It's fiction. It's like a comic. It's stuff that you are being shown. No woman really looks like this and no man behaves like that. And I think debunking the myths is so important. feminist porn happens too, simply to try to introduce an element of reality into the film. So there are attempts to redesign them, to present different images of women and men, which are a bit closer to reality maybe. I think it's really important to tackle the myth and say, look, this isn't reality. But to measure oneself against this, or to believe that this is normal or healthy sexuality, is ridiculous. I suppose we require courses in this, but I wouldn't prevent children from looking at this, because they have to learn. They're curious anyway. But it's also important, it's not just that, it's also about women enjoying their lives. Yes, that starts when you're a small child. All children, and especially, I suppose, girls. It's important to say to girls, but to all children, nobody's allowed to touch you if you don't want it. Nobody's allowed to tell you to do something that you don't want to do. Your body is yours, and you must decide what happens with it. To develop a healthy self-assurance and awareness of oneself and one's body, and the functions of the body, and the fact that we don't have to be ashamed of anything that our body does. To take the fear out of it. To say these are normal biological processes and we should be able to talk about that. It needs to start early. We have to be open about these things, and I think that's it. We now start earlier, and to ensure that we have a healthy perception of our bodies and of ourselves, and this idea, people cannot do with you what you do not want. Yes, that relates to the idea, yes, I want to do things that I enjoy, that are pleasant for me. The two things go together. Sexuality is just a continuation of your awareness of your body. As soon as you start to interrelate with other people, it's more important. And it has to start much earlier than sexual maturity. We're getting to the close now, but I have a question here about anger or rage. We talked about this a few weeks ago as well at your seminar, because if you always swallow that rage down, and that happens in a lot of cultures, then it is somaticized. It becomes a body problem, a physiological problem. And that relates to this culture about whether women are allowed to be angry or not. Well, I grew up in Italy, and I think I have a combination between cautious German and emotional Italian. I think basically it's not adequate to swallow your anger. That doesn't mean to say you have to scream at people all the time, but it needs to be externalized, the anger. You can use your anger creatively, productively. If you are dissatisfied, if you are full of rage, it can become destructive. But I think the important thing is to take that frustration and that dissatisfaction and to channel it into something positive, so that you're not undifferentiated in your anger, but you look and see, what can I do with this? What can I change? I try to change my circumstances constructively so that I can constrain or reduce that anger. So my anger is not private. No, it's voltaic. You need to find like-minded people. But the feeling that you can't control, you can at least reflect upon it and think about, how can I make it more positive as energy? It is energy. And what can I do with that energy that is not destructive but positive? What can I do with it that is constructive? Fantastic. You've been working on a project which tomorrow is going to be submitted. What's that about? Yes, our study at the Charité teaching hospital about preventing sexual harassment. It was mentioned in the newspapers, in the press. Yes, we did this research, this work at the Max Delbruck Center for Molecular Medicine. 50 people were involved in the research, and we've drawn up some guidelines based on WPP Watch, Protect, Prevent around sexual harassment in the broader sense. And tomorrow we'll be handing that over to the executive board, and we'll see what they're going to do with it. Good, great. Yes, I'm looking forward to it. And what's your next project? What do you want to do after that? Or I'm sure you have lots. Yes, we have lots of projects that we're working on. We work on 3 pillars in my chair. One is advocacy, all kinds of advocacy, the kind of thing we're doing here, for example, but also what information can I hand over to colleagues, to other researchers, to teachers? How can we set up innovative teaching? The second is implementation in medical practice, where we have a number of cooperation projects with neurologists, with cardiologists, with lots of different specialist doctors. And what can we learn from the different from these implementation that we've seen to do with treatment? What can we share with other people? This is really about medical practice. And the last pillar is organizational, where we say, okay, it's not enough simply to say to people, please do this when you start your research. Let's look at the structures and how can we design those structures in such a way that we give everyone as much potential as possible to unfold in a congenial atmosphere with no harassment, no discrimination in the broader sense. Those are the 3 pillars that we work on. And this really is the last question. What would you say to our users? What message would you have for them about gender sensitization? What should they be aware of if they feel they're not being treated properly? How do they respond? I think the best thing they can do at the moment is to ask questions. The colleagues, and I'm saying this from my perspective, doctors need to be made aware. And if they keep hearing these questions, should I, as a man, as a woman, adjust something? Does this treatment apply to everyone equally? If no one ever asks them those questions, then they're not going to be motivated when we offer them advice to pick it up. So I think it's very important that we have a bottom-up grassroots approach as well, and that people are made aware on every level, because I don't think that my colleagues are all closed-minded about these things. I'm sure they're very pleased to look at these issues, but when the questions are raised, they will address them. Doctors are very busy people. They usually have very little time. So they have to set priorities with continuous professional development, and if the questions come, it'll be a priority. Thank you very much. Thank you for your time and all the best for your work. We do need it. Thank you.